everyone, I'm Kraftin Schreyer, and I'm here to speak to you on behalf of my colleagues, Kaigh, Claire Shaffer, Emily Peoples, and Andrea Blome, about our ED medication dispensing program, which is shown to be a cost-effective way to reduce return visits and admissions. We're from Temple University Hospital in Philadelphia, Pennsylvania. The traditional discharge prescription model has many fallacies. Traditional prescribing methods typically involve prescriptions being printed or sent electronically to patient-preferred pharmacies. Some hospitals have on-site outpatient pharmacies that may be available to fill ED prescriptions, which would aid in cutting down any transportation barriers for patients. However, these pharmacies are often not open 24 hours a day, 7 days a week, which still creates difficulties if patients seek care outside of available hours. Other patients simply cannot afford medications or choose not to go to the pharmacy because they're engaging in other activities. Nationally, 15% of ED visits occur among uninsured people, and approximately 21% of uninsured patients don't fill their prescriptions. We aim to disrupt the traditional model by providing medications directly to patients, thus eliminating the need to go to a pharmacy to pay for and fill their prescriptions. Previous studies have looked at medication dispensing programs. One, out of the University of Maryland, gave 243 patients a complete course of to-go medications and tracked their return visits within 7 days. In the to-go group, only 2.5% of patients returned versus 5.9% in the control group. They specifically looked at cellulitis, in which group 1.6% returned, whereas 6.9% did not in the control group. However, they did not evaluate readmissions. A study out of New Mexico also looked at 30-day returns for take-home medications versus paper prescriptions, but they looked at all medications, not separated by discharge diagnosis, and again did not look at repeat admissions. Our program included 10 medications, including 8 antibiotics and 2 for asthma. One additional antibiotic, Augmentin, has since been added, but wasn't included in our pilot, so was not included in this preliminary data. For all medications, a full course of treatment was dispensed to each patient at no cost. Our program was started in February of 2019, and then we monitored the program for the next 6 months. We looked at return visits to the ED and hospitalizations within 7 days and 30 days. This was then broken down by total and specific conditions. Finally, we did a cost analysis to evaluate the program. This slide looks at our total results for 7 days and 30 days. On the left-hand side of the graphs, you can see the percentage of patients divided by the ED returns and admissions in the pre- and post-period for medication dispensing. During the 7-day time frame, the ED returns changed from 8.4% to 8.12%. Admissions changed from 3.2% to 3.87%. In the 30-day time frame, returns decreased from 12.6% to 7.2%, and admissions decreased from 5.4% to 2.4%. Looking specifically at asthma, using graphs with the same configuration, in the 7-day window, ED returns actually increased from 14.78% to 18.86%, whereas admissions decreased from 29.69% to 3.95%. In the 30-day time period, returns again increased from 22.07% to 25.88%, whereas admissions decreased from 22.27% to 3.51%. We lumped all the antibiotics together into infectious diseases to investigate those outcomes. In the 7-day window, returns decreased from 23.99% to 9.01%, and admissions decreased from 13.91% to 3.73%. In the 30-day time period, a decrease was seen in ED returns from 44.94% to 3.42%, and in admissions from 6.15% to 1.55%. For our program, the cost of each dispensed medication totaled $15. The total cost of dispensed medications, of which there were 612 during the study time period, totaled $9,180. Based on prior studies at this institution, we determined that revenue collection for discharged patients was $151 and for admitted patients $6,345. Therefore, for a total of 542 patients, the total cost of reduction in discharges was $10,192, and for admissions, $291,870. We found that within 7 days, there was a reduction in ED return visits, and within 30 days, a reduction in ED return visits and a reduction in admissions for infectious diseases and asthma. The impact was much greater for infectious diseases. For a cost of only $9,180, over $302,000 was saved in ED return visits and hospital admissions. This shows that a medication dispensing program is an extremely cost-effective way to reduce both ED return visits and subsequent admissions in conditions such as infectious diseases and asthma. Thank you, and with that, I'm happy to take any questions.